Hello everyone. Today we discuss about the oncologic emergency. I am Dr. Balkishan Gehlot from Medical Oncology Department. There are many critical oncology emergencies like spinal cord compression, superior vena cava obstruction, and central airway obstruction. Other than this is the tumor lysis syndrome, hypercalcemia due to induced by the oncology emergencies, but we discuss first at all about the spinal cord compression as a oncological emergency. And because of spinal cord compression having many symptoms other than oncology, there are survival reason for the spinal cord compression, but we discuss about the only malignant spinal cord compression today. So let's be started the first at all spinal cord compressions. First, we overview about that. We discuss about the epidemiology, pathology, clinical feature of malignant spinal cord compression, investigations to do, and what are the management of the emergencies, and what are the summary about that. So let's be started with first at all epidemiology. That malignant spinal cord compression, on that is the compression by that cancer affected 5 to 10% of the cancer patient. This is the doing in one journal is in 1902. Majority of the patient of the spinal cord compression is our age more than 50 years, but cumulative incidence that is to be decreases with age. Okay, so due to lung, that is 25% of the chance of this malignant spinal cord compression. Due to prostate is to be 16%, multiple myeloma is to be 11%, and breast cancer is to be 7%. That is the presented in Lancet Oncology 2005 journal. 20% of the patient that having the lack of the cancer history. We discuss about that some reason other than cancer also causing the spinal cord compressions. So this is the type of this. And in pathophysiology, that is to be most of the spinal cord compression is are mainly vascular. Okay, that is mainly vascular rather than mechanical causes. That is more vascular causes is to be in pathophysiology. First at all are tumor, that is extension into the epidural space. Okay, that is compressions of Batson venous plexus, that is increase in the vascular permeability and the edema. Okay, that is increase the pressure on the small arterioles. This is the finally this then the occlusion of the small arteriole, and that is a structural in long standing cases. So that are the basic reason, that is the pathophysiology mainly, because that is more causes vascular reason than is the mechanical reason to spinal cord compressions. Okay, and after that we show that any of the four mechanism by which spinal cord compression is to be done. And first at all, this is the expansion of a vertebral bone in the epidural space. Second, neural foramen extension of paraspinal mass. Third is the displacement of any bony fragment into the neural foramina following the destructions of a vertebra, and rarely is a primary hematogenous seeding into the epidural space. So that is are the many reasons. First at all, tumor itself going into the epidural space, and tumor is compression the neural foramina as paraspinal mass, and the displacement of any bone fragment into the epidural space, and last and but rarely that is a hematologically spread in the epidural space, that is also caused as a malignant spinal cord compression. Okay, so what are the clinical presentation of this spinal cord compression? So in clinically, common symptom is in decreasing order, that is that is also in Lancet 2005. Back pain in 70 to 90% cases, mostly due to neurological deficient or by the 7 week. Okay, so when neurological deficient 7 week is to be present, then back pain will be started. Motor deficient is to be 60 to 90%, sensory deficient in 45 to 90%, autonomic dysfunction is to 40 to 75%. pain is aggregated by the lying down position. New onset back pain, that is a red flag sign in the cancer patient. Common cancer cases that malignant spinal cord compression we previously discussed, mostly the lung, then prostate, then breast cancer, multiple myeloma. That is our cases the more than 20% cases of the spinal cord compression. You know about two things in the clinical presentation. First at all, neurological deficient more than 7 weeks, that is created back pain. Second is a red flag sign is new onset back pain in every cancer patient, that is indication mostly that is a spinal cord compression, or that is the type of pain in the spinal cord compression. First at all, biological, one is mechanical, radicular and funicular. In biological, that is the cause is irritant or destructions of the vertebral periosteum, PCL or facet joints. So that is a feature is a night or the morning pain presented even when lying down position, because that is a destructions of bone, that is called biological bone. One is to be mechanical, that is created by the spinal instability, that is movement related pain. Okay, radicular pain is a compression or infiltrations of the nerve root. This is the radiation along the distribution of the nerve and the positioning in nature. That is a radiating pain is radicular. One is funicular, that irritating of long train in spinal tract, that is a constant, and the diffuse pain regardless of the position. So biological pain is due to destructions of the bone, mechanical due to spinal instability, radicular due to compressions of the nerve root, and the funicular is the irritation of the long tract. So in biological pain, that is present even lying down position, that is the important thing, and mechanical is movement related, and the radicular is to be radiate along the tract, and funicular is constant pain. So that are the type of pain. One is clinical examination. During the clinical examination, we thought that motor power. Motor is a power, tone, deep tendon, reflex, clonus. Sensory is a sensory level. At the level, a band-like sensation is to be presented. Sensation from the sacral area or anal sphincter area. So that is the different region like upper cervical, lower cervical, upper thoracic, lower thoracic, lumbar and sacral. And that is a corresponding vertebral body that is to be doing. This is the table, and this is also a diagram show that different level and corresponding structures. One of the important sign is to be called the Beaver sign. Beaver sign when presented due to lower thoracic cord injury, which is causes paralysis of the lower abdominal muscles. So that is showing the upward movement of umbilical when attempting rising head from the supine position due to unapposition of upper abdominal muscle, because lower abdominal muscle is to be paralysis. And what are the investigation to do in case of spinal cord compression? First, very good investigation is to be MRI of the whole spine screening, and after screening that we doing, if any defect, then doing the full MRI. Okay, that is on sometime because of multifocal lesion is to be present and the different spinal level in 1/3 of cases, so we always doing the whole spine screening. Okay, so that is also in Clinical Oncological Journal 2022 2002. T2 weightage image, look for the thickle sac indent, that is very important. Okay, this is showing this image is to be show that compression by the vertebral mass in extending into the epidural space. This is the vertebral mass, this is extending into the epidural space. Okay, so tissue diagnosis is necessary, because if you treat the patient, then you diagnosis by the biopsy is to be necessary. If unknown cases, HRCT or CT myelogram in condition, MRI will be contraindicated, like the cardiac pacemaker, any metallic implant, patient having the claustrophobia. So hypercalcemia may be presented with extensive vertebral metastasis, that is another cause. This is the CT myelogram. Different form of the spinal cord compression, showing that compression, this is by the paraspinal mass. Okay, this is the paraspinal mass shown in MRI, this showing the in compression of vertebra, and one is the bony fragmented is to be done, and this bony fragmented is to be doing the compressions. So that is at the grading of this spinal cord compression by the Bilinski malignant spinal cord compression grading scale. There is a two type of grading, one is to be 4 point, one is to be 6 point, but 4 point is to be easiest, so we using the 4 point. 0, that is only vertebral lesion, and 1 is to be epidural extension is called 1A, and the thecal sag extension 1B, and touching the cord is 1C. 2, that is 1 plus spinal cord compression without blocking the CSF, and third is to be 2 plus blocking the CSF flow. That is at the different. 0, that means only vertebral lesion, and 1 is to be going extension like in epidural, like in thecal sag and touching the cord, and second is to be spinal cord compression but without CSF blocking, and third is to be blockage of CSF fluid. This is called the Bilinski grading. So what are the management of this malignant spinal cord compression? First at all, this is a oncological emergency condition. If you not treated this time, this created a permanently neurodeficient condition. So what are the basic treatment object? That is to be pain control, that avoidance of the complications, preserve or improve the neurological function. Patient should keep on the bed rest, provide the adequate analgesic for the care. So there is a thing to be considered. First at all, histological diagnosis is to be needed. It is necessary to get the biopsy from the spinal cord lesion when the primary is to be unclear, unknown staging of the tumor. So radiotherapy and chemotherapy, steroid, that according to this lesion. Second step is to be initiated of the corticosteroid. When you doing the biopsy, we started the corticosteroid. Okay, 2 regimen of the steroid will be doing, that is very important. 2 regimen, one is to be high dose, that is called 96 mg loading dose, followed by 96 mg in divided 4 doses. Second is to be low dose, that is 10 mg loading dose, and followed by the 16 mg divided into the 4 doses. Superiority of the one regimen over is to be unclear, that means both regimen is to be usable. That is also proven by the randomization trials, that is 2 regimen are the same. So 1 ppi is always used for gastric protection when we using the steroid, that is know you about, and evaluate the life expectancy, performance status, and extension of the disease, and the systemic treatment option after we starting the steroids. Okay, so step 4 is called is a algorithm, that is called MNOP algorithm. That is very important. After we started of the first we doing the biopsy, if not unclear the diagnosis, second we started the steroid, and third is to be use MNOP algorithm. M matlab that is mechanical instability of the spine. When presenting, consider up to the upfront surgery to stabilize the spine first. N is to be neurological deficient, whatever the present and for how long. O, that means oncological, so is the radiation dose as per tumor biology for sufficient, whether the treatment is curative for macroscopic disease and is to be microscopic diseases, or the palliative, that is oncological treatment is called O. And after that is to be P, that means a preferred treatment, that is to be surgery, or that is a Lancet 2005. It was the first phase 3 RCT trial that comprised the decompression surgery and the surgery and spinal stabilization within 24 of the diagnosis, followed by the RT versus RT alone in the same cases. So you discuss that is to be surgery plus radiation and the radiation alone. You thought that ability to walk the post treatment rate is to be 84% when both modality use, and only RT is to be 57%. That is are the some you thought that all are the benefited as compared to this radiation alone part. So decided finally that is to be preferred treatment of instability, that is surgery, doing the decompression, and then what after that doing we treated the cases. So one important scoring system of the clinically improvement, one is to be Frankel score. This is the show grade A, that is to be complete, B that means is sensory only loss, C that means a motor non-functional, D is to be motor but functional, and E is to be recovered. That is the Frankel scoring system to show that only nerve functions. One is to be Asian spinal scale, that is also important. So that is show the A is to be complete, B is to be incomplete, C is to be incomplete, D is to be incomplete, and E is to be normal. A that means complete, no motor and the no sensory function preserved in the sacral segment. That is to be different areas and the different type of the scale using for that spinal cord preservation and motor functions and all. So surgery, so we doing that surgery is to be indicated when KPS score is 40 plus, unstable spine at least 3, or according to praise and according to Davita 2-month life expectancy to be needed, or duration of paraplegia is to be less than 24 hours, or intractable pain and rapid progress in spite of RT or unknown primary tumor, relatively radiosensitive tumor or the bone fragment impeding. In that way situation we doing the preferred treatment as surgery. Okay, so in the surgery traditionally use the posterior laminectomy, but now it to be absolute. Now we using the 360-degree decompression and a co-commitment stabilization done with the modern technique according to Lancet 2005 trial. And kyphoplasty or the vertebroplasty, that is are also relative contraindication according to NCCN guideline. So second is to be treatment option radiation, surgery followed by radiation, that is better in terms of regagging and the maintenance of the motor function, maintenance of the constitution and pain control, overall survival, maintenance of the Frankel score, and that all are increased. Then RT alone, but survival schedule is to be present, that is to be 15 fraction to 20 fraction, 10 fraction schedule, 5 fraction schedule, single fraction schedule. Short course RT schedule is are associated with more retreatment rate because higher incidence of local recurrence and requirement of the higher dose of analgesic afterward according to Irozob study 2003. Shorter course schedule is are used in the patient that having the short term life expectancy. So always not mostly is in current scenario using the 8 gray single dose, 20 gray, this type of the doses only used in palliative cases, not in the all cases. If the patient is to be treatable, then we not using this type of schedule, we using the full dose of the treatment. So what are the RT field size we using? If you based MRI planning, then you use the 1 plus vertebra up and down. If you using CT based planning, then using the 2 vertebra up and down. And we using as a APPA field in the thoracic or the lumbar vertebra region. Laterally opposed field is to be used in cervical region. SBRT, that is important for radical treatment only in case of radio resistance tumor to escalate the dose and re-irradiation for a recurrent lesion. At least 6-month gap between the treatment is to be a recommendation. That is shown in palliative medicine 2015. And radiosensitivity of tumor as per histology, that is to be very radiosensitive is to be lymphoma, germ cell, multiple myeloma, good sensitivity breast, prostate, HPV positive, unfavorable issue HPV negative cancer, non-small cell lung cancer, GI tumor, and resistance to be melanoma, sarcoma, and this type. Constant chemotherapy is to be used. Chemotherapy useful in the germ cell tumor, lymphoma, neuroblastoma, breast and prostate cancer as a hormone manipulation, and supportive care and rehabilitation about that. Brass and the collar will be used as for the physical medicine opinion. For paraplegic patient is the thigh length compressive stocking, and surgery if we using as a higher risk of thromboembolism, so low molecular weight heparin like enoxaparin वगैरह वो देना है पेशेंट को. वन इज टू बी पैराप्लेजिक पेशेंट शुड बी प्रोवाइड विद एयर मैट्रेस और कुशन विद एवरी 2 to 3 overly posture changes to prevent the decubitus ulcers in patients. And another is to be catheterization for the urinary bladder, and that is to be uses, and the silicone catheter can be kept in situ in the 3 month for long standing. Judicially use of laxative, psychologically support to the patient is to be given. So what are the prognosis about that? According to malignant spinal cord compression has a median survival of the 6 months, and only 1/3 of the patient is live beyond the 1 year, according to the Sonsteren et al study in 1990. Rapidity of the symptom onset most important, and the rapid involving compression carrying a worst prognosis. Radio sensitivity of tumor is another factor. Pre-treatment ambulatory function is to be another treatment, and overall tumor burden, that is also the factor for prognosis. So one important is to be a scoring system is called the REDIS prognostic scoring system. First score that predict the overall survival in patient of metastatic spinal cord compression, that is developed in 2008, that is dependent on the type of the primary tumor, bone mets at the time of RT, visceral mets at the time of RT, interval the tumor diagnosis or malignant spinal cord compression, ambulatory status before RT, and timing of the motor function deficient. So according to this we doing using the different points to patient. Total scoring is 20 to 30, that is to be 6 month survival is only 16 month. If 31 to 35, that is survival is 48 month. If the 36 to 46 scoring, that is to be 81 month. That will be more score, that is more chance of the survival. So in case of pediatric malignancy, tumor biology is to be different for malignant spinal cord compression. Most common neuroblastoma, that is commonest other than Ewing sarcoma and Wilms tumor. Pathogenosis, that is tumor extension to epidural indirectly, so called the dumbbell tumor. Usually chemotherapy is a play key role in this type of the tumor, and the tumor rapidly progressive despite of the chemotherapy. RT is used for only palliative for when all modalities to be fail in pediatrician. So that is the summary. Malignant spinal cord compression affected 10 to 20% of the cancer patient. Suspicion is to be known in cancer patient when new onset back pain without cancer with progressive worsening. Do MRI of the spine, whole spine, and looking for hypercalcemia also. Don't start steroid when unclear of the suspected of lymphoma. Use low dose steroid regimen as compared to high dose, because high dose causes the more adverse effect without more beneficial. So doing the upfront surgical decompression followed by the RT. This is the patient of life expectancy if more than 2 to 3 months. The systemic burden of disease less when the spine is unstable. For curative treatment, SBRTs show the main role. Use the short course RT in other patients like in palliative, and adequate rehabilitation is to be measured. That is very important about that malignant spinal cord compression. Thank you.